Hi, everyone. I'm so sorry to interrupt the free-flowing conversations. I feel like I'm a menace in interrupting. So I please encourage everybody to continue the conversations after. But for now, I guess we have more very interesting panelists, and I don't want to waste any time and make sure that we cover all the information. I guess before I introduce our next panelist, I should introduce myself. My name is Priya Sable, and I am a PhD student at the University of Toronto. And my research is looking into like long-term settlement of a South Sudanese community, actually, in southwestern Ontario. So I came across the team behind this conference, actually, and was introduced actually relatively recently. So I feel very privileged to be able to be a part of this. And anyway, I hope that you all continue to enjoy the enriching information that is going to be bestowed upon us. So without any further ado, our next presenter is Professor Bukola Salami, who currently holds the rank of full professor in the Department of Community Health Sciences, Cummings School of Medicine, University of Calgary. Professor Salami's research program focuses on policies and practices shaping migrant health as well as Black people's health. She has been involved in over 90 funded studies, totaling over 230 million. She founded and leads the African Child and Youth Migration Network, a network of 42 scholars from 4 continents. She led the establishment of the Institute for Intersectional Studies at the University of Alberta. In 2020, she founded the Black Youth Mentorship and Leadership Program. Her work on Black youth mental health informed the creation of the first mental health clinic for Black Canadians in Western Canada. She has presented her work to policymakers, including to the House of Commons Standing Committee on Health. And her work has been contributed to policy change, including the ones that related to Black people's well-being. She is an editor for the Canadian Journal of Nursing Research and associate editor of the Canadian Medical Association Journal. Additionally, she is an advisory board member of the CIHR, Institute for Human Development, Child and Youth Health, and Scientific Advisory Committee on Global Health to the Government of Canada. So if you please help me welcome Professor Bukola Salami.
He's not gonna like that. I'm gonna say what I'm about to say. What am I about to say? I actually sent Ibuka another presentation, and Ibuka's like, no, focus on immigrant health. I went on my own tangent. Thank you, everyone, for being here, and please give me a clue when I have about 5 minutes left. So I'll talk about, thank you. Excellent. I'd like to acknowledge that beyond the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinabeg, the Chippewa, and the Rose, not you don't know, I hope, and the Wendat people. And we are also, and is now home, and the city of Toronto is now home to many diverse Indigenous people. And I must say that I have a strong commitment to Indigenous self-determination and also work in parallel paths for the benefit of Indigenous people in Canada. And I'm also mindful of the many broken covenants and promises, and I strive to make it right with the land and with each other. So I'd like to acknowledge my Canada Research Chair and Public Health Agency of Canada and CIHR Institute. I'll be drawing on some of the work, and I think the other work I'm drawing on is Women and Children's Health Research Institute. So I'll discuss about Canada's history of xenophobia, and I'll discuss my research findings related to mental health and access to health care, and identify strategies for integrating intersectionality into immigrant health service provision. So we know that Canada has a history of discrimination towards Indigenous people in the form of residential schools, forced sterilization. We have slavery of both Indigenous and also Black people. We have Canada's racist immigration policy, and we have the Chinese attacks. We have the Komagata Maru, which was towards South Asian people in the borders of BC, and Japanese internment camps. So this is just some of our history that we have in terms of discrimination. We did have a law in 1910 that also actually had a policy that said, if you're not white, you're not going to survive Canada. So we're going to protect you and say, your skin color cannot survive the climate and requirement of Canada. So governing council proclamation was made that prohibited for a stated period or permanently the landing in Canada or the landing at any specified port of entry of immigrants belonging to any race deemed unsuitable to the climate or requirement of Canada. So we had that. So if you know about the 1967 immigration policy, that was what changed that. So between 1910 and 1967, if you were trying to come to Canada, and that's why you won't see too many immigrants that would say they came before 1967. Of course, we had the, what's the name of this? Domestic workers scheme during that period. But a lot of, there were some immigrants between 1910 and 1967 that were basically said, we are trying to protect your skin color, so do not come here. And just in case black people did not know that we don't want you here, black people, it was also proclaimed that the Negro race is deemed unsuitable to the climate or requirement of Canada. The second one did not, pass, but of course it had implications, and the first one still existed that actually covered anyone that was non-white from being able to come to Canada. So I'll also talk about some of my work that I have done on mental health of immigrants. This is, I did some work some years ago to look at mental health of immigrants, and I drew on the Canadian Health Menu Survey, which is a national survey. So the most commonly used when you look at mental health of immigrants from a national perspective is the Canadian Community Health Survey, and a lot of researchers have used that, and I wanted to use a different one, the Canadian Health Menu Survey, which I think it was just in the last 15 years that this survey started to look at the mental health of immigrants and non-immigrants, as opposed to the Canadian Health Menu Survey. The Canadian Community Health Survey has a smaller sample size. And you may also notice that now we have another survey that is like a mental health survey that I think just got released by Statistics Canada, that you can actually specifically analyze mental health of immigrants. So I looked at a total, I think at that time I lumped three groups of, 3 cycles of the survey together, which produced about 12,000 participants. And when you look at this, you'll see that immigrants on average earned $10,000 less than non-immigrants in Canada. But if you look at the educational education, that they tend to also have a higher, immigrants tend to have a higher level of education than non-immigrants, which is consistent with many of the data that we have. So when we looked at the mental health of immigrants, consistent with the LD immigrant effect, and I'm sure people have already mentioned the LD immigrant effect, that immigrants tend to arrive in Canada with better health than Canadian-born population, and that is because of selection factors in the process. And of course, that immigrants, when you lump immigrants and refugees together, immigrant health tends to overshadow the health of refugees because immigrants, there's a bigger population of immigrant than refugee population. We found that there was no statistical difference between immigrants and non-immigrants on self-perceived health after we controlled. However, we found that individuals, so when we looked at people by 5 years, 10 years, 15 years, that individuals who had lived in Canada for 5 years said their mental health was actually better. And when people had lived in Canada for 5 to 10 years, then they really, really say, my mental health is really bad compared to immigrants. We were in the lab a few times, and we manipulated data, put in different variables. No matter what variable we put in, things that always showed that a strong influence on mental health was income and community belonging. And the good thing about income and community belonging, the bad thing is that disparity exists. The good thing is that it's actually amenable to social intervention, right? When we did ask people and we did interviews in Calgary and Edmonton, and we asked immigrant service providers. So we did interviews about around 50 to 55 immigrant service providers. And when we said what contributed to and what can help to promote community belonging, they talked about natural environment. And then I'm like, okay, so what's that natural environment? Parenting programs. When people are in the parenting programs, children start talking together, parents start talking together, phone numbers get exchanged, people now start feeling like their sense of community. Now that's from the perspective of immigrant service providers. So again, very strong versus very weak, about 3 to 4 times higher level of mental health when you have a very strong sense of community belonging. So some of the factors, when we interviewed about and did focus group with about between 50 and 55 immigrant service providers, some of the factors that they said contribute includes unemployment contribute to immigrant mental health, unemployment and underemployment, immigration status, community belonging, family dynamics, gender discrimination, time since migration, culture shock, and parental stress. Now, because of the limited time I have, I cannot go in depth into one of this, but I would show some quotes that indicates what they said. In the beginning, they are facing like their language problems as well as their income. I think income problem, and they are finding related job, and especially if someone is having good kind of education, good degrees over there, but like denying their credential here, not accepting. So it's also one of the reasons of unrest here, because they are not finding themselves satisfied. So unemployment, income inequality, and the influence of that. Immigration status was also, so refugees have a distinct set of mental health needs because prior to arrival, so you're looking at the pre-migration that has been really talked about in the literature and post-migration factors that does influence refugee mental health. And also temporary foreign workers. So I did also some work in the past on temporary foreign workers. I had a short project that looked at temporary foreign workers and their transition to different status in Canada. And I remember there was one focus group that I did specifically for temporary foreign workers. And I asked them about mental health, and they all looked at themselves and they're like, I think we all know we have a problem, but we have a lot of things that we need to deal with. Right? So oftentimes for temporary, there's another one that I did for temporary foreign workers. That the service provider told me, and this was not about mental health, that the service provider told me that she often gets temporary foreign workers that will come to her and, they're pregnant. They know that if they tell the employer they're pregnant, they just realize that the job is gone, but they don't know why they don't have a job. So they come to her and they're like, talking to her and they're like, okay, trying to sort of get her to help them make the decision or support them towards the decision of, abortion, because of course of having to really juggle your reproductive care your reproductive needs, and also your ability to be able to stay in Canada, which of course is contingent on your ability for your employer to continue to hire you. There's another temporary foreign worker that I spoke to, and this person told the story of someone that had a problem with the liver. And they hid it. They didn't seek health care. They didn't go to doctors because they were afraid that they wanted to apply for permanent residence. And if someone knew, then they would not be able to transition to permanent resident status. So they hid the condition. And by the time at some point, it was not, they couldn't continue to hide it. And at that time, they actually were not the condition was much worse, and at the same time, they weren't able to stay in Canada. Community belonging. So, this was a story of, we had a gentleman working in our office, and the gentleman, I think this was from Syria, and, they're like, the wife is packing, she wants to go back to Syria, and that was at the, when things were at the height of, the war in Syria. And, because she was so stressed, she didn't really have anyone. So what they did is break a lease from a community that she was in where no one spoke her language. She wasn't really connected. And they moved her to somewhere where she could actually have people that spoke her language and people that she can connect with. And that helped her in terms of our mental health. And that was given as an example of the importance of community belonging. Racism and discrimination, I call it actually a silent killer. The silent criminal is discrimination at work, discrimination at school, discrimination at several places. When we asked about factors affecting access to mental health services, immigrants, named several factors, including mental health stigma, mismatch between cultural needs, the economic outcomes, the language barrier. So I remember one of the favorite quotes from a mental health service provider was, she said, to us, they're all Afghanis. To them, the Afghanis from the Pashto tribe, and I'm just using how she said it, the Afghanis from the Pashto tribe and the Afghanis from the Taliban. And those two are not going to talk to each other. So if you bring someone from one community and the other community, you're like, okay, everyone is from Afghanistan. But then, you actually bring in, someone that views themselves as oppressor and oppressed together, and then that actually prevents any sort of therapeutic relationship. So I also did some work to look at mental health of Black youth post-COVID-19 pandemic. Actually, no, this one was not about mental health of Black youths. This one was earlier. So the first one was, the role of technology. And, I think the first quote is not just about technology too, it's just about knowledge of healthcare providers that you call Outlink, and the first thing they ask you is your child blue, and you're like, okay, I don't see the blue. My child is Black. And so it's not just about technology, but also the knowledge. So when you work in technology spaces, you need to have, to have a level of competence to be able to actually navigate that. I did some work on Black youth and about mental health post-COVID-19, and some of them talked about, during COVID, how they were in school, online, and, of course, most of them, they had challenges with that. I should also say that, during COVID, I run a Black Youth Mentorship Program to socially and economically empower Black youths, and Black youths will join online for the mentorship program. And throughout COVID, I had these 4 computers that I shipped to people's homes. So we wipe it, we wipe the computers, make sure there's no data on it. We ship it to the youth's home because the best they have is one cell phone for everyone in the house. Right? So when we're talking about, integrating technology, we also have to think about income inequality and how that may structure people's access. The other thing that you spoke to us about was, not in this quote, was about, let's say you have, a mental health challenge, and you went to see let's say, you're 18 or 19. You have a mental health challenge, and you go and see a psychiatrist, and the next thing is the psychiatrist calls you for a meeting, and they're asking you questions, and your parent is right there. Like in Canada, you're 18, and you're supposed to be independent, but we know in many of these countries, you get independent when you leave your dad and mommy's house. So the challenge there in terms of confidentiality. This person also say, in terms of virtual mental health delivery, that it doesn't help, that, there are many meetings that are happening, and, people just feel like everything is all virtual nowadays. So that is some of the challenges. Oh, 5 minutes, okay. I'm almost done. Oh, sorry, I just had to show this picture. We had Professor Kimberly Crenshaw. We had her in Calgary. I invited her to Calgary, and she gave a presentation about intersectionality and the increasing war on equity, diversity, and inclusion. So how can you integrate intersectionality into this? So many of you know that intersectionality explains how the intersection of diverse social race, gender, sexuality, and social class produce multiple and intersecting streams of oppression, social and health inequities. And we know that oftentimes people will integrate intersectionality or say they are integrating intersectionality without considering social justice and power. Intersectionality is within a critical theoretical paradigm. And of course, you cannot think intersectionally without actually thinking about power relations and how power relations have actually structured us across in terms of our relationships. Its central is researchers' recognition of power and oppression, and researchers' intersectionality are just as integral to the research being produced as those of individuals. And so when we are thinking about intersectionality, it's also very important that we recognize our own positionality and also we are reflexive. So some of the key ingredients in terms of intersectionality is thinking about power, about oppression, about social justice, relationality. And when we think about relationality, we are thinking about not just in terms of we are all interconnected, but also thinking oftentimes, oppression of one person leads, a privilege of one person is actually the oppression of another person. So how do we actually navigate those tensions? And also, context is also very, very important, and complexity. Recognizing oppression implies acknowledging that power works in uneven ways and organizations of hierarchies of power. This requires researchers to reflect on the knowledge production process and embedded relations of power. And complexity recognizes diverse forms of identity. So I think, when people actually think intersectionality, they think about complexity, they think about complex analysis in their work. And relationality emphasizing interconnections of people and concept. The marginalization of one is connected. And deconstruction, even though intersectionality, we are thinking about categories, but deconstruction also recognizes that many aspects of social categories, such as race, are fluid and are also social constructs. So, oftentimes when I think about race as a social construct, people don't really understand in terms of what I mean by race as social construct. And I talk about, for example, the case of President Obama. President Obama, what's Obama's race, right? People will say that Obama is a black man. If Obama went to South Africa, Obama will be colored. He's not black, he's not white, he's colored. So it's changing in terms of social context. And Mergamoko too, geographical social locations, or the other person I think about is Merkel. To me, she used to be white, at least I thought, until crazy things started happening in the palace, and then she became more and more black, right? So that is how you think about intersectionality, think about race as a social construct that changes with time and also with space. So some of the implications of this is consider addressing intersecting social determinants of health. People have also often told me that, for example, when we think about the Afghanistan community or the black community, that it is not community, it is communities. There are communities within communities, and really, really attending to that context is very, very important, right? I have in the past looked at, what are culturally appropriate ways to collect data from black populations, and I would go, for example, to one community, and what they may tell me may be a little bit different from what they want from another community. So really, really that context. Social justice and addressing power. Thinking about the technology divide, including the contributions of income inequality to those divides, and how do we actually bridge that to address inequities, considering the pre-migration and post-migration factors shaping immigrants' health, addressing racism and discrimination experienced by immigrant population, and also fostering a sense of community belonging. And I think one of the things that we need to more think about as we integrate technology is how do we foster technology within this, within this land, how do we foster community belonging within this landscape of increasing technology? And also exercising reflexivity and examining one's social positioning. Sorry if I took too long. Thank you.
Thank you so much, Professor Bukola. I will ask everyone to please hold your questions because we will have time and to do a Q&A after all the panelists are finished presenting. Okay, so it's time to introduce our next two speakers. First, we have Professor Nancy Clark. Nancy Clark is a first-generation settler, immigrant, and racialized scholar who conducts social justice, intersectionality, and equity-oriented health and social science research with people who experience mental health challenges due to social determinants of health such as racism and forced migration to countries in the global north. Dr. Clark is Director of Social Justice Studies and Associate Professor at the Faculty of Human and Social Development, School of Nursing at the University of Victoria. Dr. Clark is an affiliated researcher, University of British Columbia Center for Migration Studies. And with Professor Nancy Clark today is Dorota Guzek, who will be starting at University of Victoria this fall as a graduate student of Dr. Nancy Clark. So without any further ado.
Thanks so much for that introduction. And actually, we're moving to a Faculty of Health, so that's why there's that. Okay, so what can I say as the last speaker that has not been said? First of all, I wish to acknowledge that we're visitors on this land, University of Toronto and the Women's College Hospital that's on the traditional unceded territory of the Huron-Wendat, the Seneca, the Mississauga of the Credit. And today we're meeting in this place, still home to many Indigenous people, and we're grateful to have the opportunity to visit the place and participate in these conversations with you. We also want to acknowledge that this is where we're situated. We're working and living and privileged to be on the unceded territory of the Algonquin-speaking people, the Songhees, the Esquimalt, whose traditional territory and and relationship with the university continues. This is a picture of the University of Victoria, and the land that juts out there in that peninsula is Wasanich territory, and that's where I have the privilege to work, live, and play, but not so much play. And so I think it's important at this time in history that we also consider the link between colonialism, borders, and how forced displacement has impacted Indigenous communities across Canada, but also the communities that we're working with. And I guess before Dorota introduces herself, one of the things we're going to talk about today, a lot of the things you've heard, but we're just going to talk a little bit about mental health, provide a little bit of a retrospective policy analysis. Ubakan said, well, what do you want to talk about? I said, I don't really know. And she said, policy. So I said, okay, that means everything. But what we're going to focus on is upscaling. What does upscaling mental health care for people of forced migration mean? And Dorota will specifically speak on aspects of integrated mental health care called digital mental health or M-mental health. And Dorota, would you like to introduce yourself?
Sure. Thank you very much, Nancy. And thank you very much for having me here today. So I'll just give like a little bit of a background on myself. So I'm professionally trained as an RN, and I have a master's in international health with specific interests in international public health, especially in relation to low and middle income countries, evaluation, and e-health. And I have been previously involved in some research projects related to medical e-learning evaluations in low and middle income countries, M-health evaluation, as well as migrant and refugee models of care delivery. And I will be furthering these interest topics in my upcoming graduate studies at the University of Victoria.
Thanks, Dorota. So I'll just move to the next slide here. How do I do that? I'll just push, okay. Oh, this here? Okay, great. Okay, what are we looking at? Okay, what do we know? So this is not new, but it's estimated by the end of 22 that there's going to be approximately 108.4 million people that have been forcibly displaced. And about 35.3 million are considered in a refugee category requiring protection. Some are asylum seekers, approximately 5.4 million, and they make up about 38% of that 108.4 million people. And what we're going to focus on today is forcibly displaced due to persecution, war, conflict, generalized violence, and human rights violations. So I think it's important to keep that in mind when we're thinking about forced migration, movement of people, and the ethics of care when they resettle in a country like Canada. And in both in high and low-income countries, nations have not adequately prepared for the large influx of immigrants. And we know that it's already stressed and already fragmented mental health system, resulting in least access to care pre, during, and post-migration. So for people who experience forced migration due to war, we know that their mental health impacts are compounded. What we heard from several speakers today and in previous sessions, that pre-migration experience really sort of foreground what happens after. And the World Health Organization suggests that 1 in 5 people, about 20% of people that have experienced war and armed conflict, will go on to have a mental health condition, meaning a diagnosis. And overwhelming research has shown that war-related trauma and refugee stress are associated with increased both physical as well as mental health. So we need to keep that in mind as when we're thinking about mental health, not to lose sight of the chronic comorbidities that are associated with things like depression, anxiety, psychosis, hypertension, diabetes, and cardiovascular disease. But as many of you know, these are compounded in the post-migration context. Oh yeah, okay. And so I liked that some of the speakers today talked about history. What's happened in Canada? What are the laws? What are the policies that have shaped our immigration policies? I was the beneficiary of coming to Canada in 1974 from what is called Palestine and also the former Yugoslavia. So both those countries, my parents could not stay in those countries, so we came to Canada. My father's Palestinian, my mom is Serbo-Croatian. So I guess, Bukola, where are you? I would be considered colored, maybe? I don't know. Okay, so anyway, what do we know? So I always go back because part of my, when I started my doctoral studies, I was like, wow, what's happening in Canada with people of forced migration? And so I went back, and in the 70s to about the 2000s, research described interaction models. And I'm a healthcare provider. I'm a nurse by training. So I'm always interested in like coordination of care and systems, and what does that look like? And so I was interested in what did we know about interaction models where health is determined by what happens after migration and the social environmental factors. And at that time, a fellow by the name of Dr. Morton Beiser, who you may have heard about or read about, started to develop explanatory frameworks around understanding what are the mental health impacts. So that was quite a long time ago. And at that time, there was a very influential document called After the Door Has Opened. The Canadian, that was developed with the Canadian Task Force on Immigrant and Refugee Mental Health. And it really had inroads toward enhancing the factors around mental health, but it also probably was the first longitudinal study in Canada, I think, that looked at post-migration factors, things like gender, employment, that you've heard about, education, language, and how that might link to pre-migration trauma stress. And then in about 2019, the World Health Organization, in collaboration with the International Organization of Migration and the Office of the United High Commissioner for Refugees, developed a draft action plan. And that action plan was to promote public health interventions, to promote continuity and equity of care, and to look upstream. In other words, to look at migrant mental health and put that in the global spotlight around for all countries in the West. Sorry, I just need to read my notes here. I don't know how to do that. Okay. So finally, also at that time, World Health said that we need better evidence for healthcare, and we need to counter misconceptions about migrant refugee health. So doing a retrospective analysis and hearing what we're hearing today, I'm questioning what has actually changed. We know that in 2002, Canada changed its immigration policy to actually include those protected groups that Bukola talked about that were previously excluded due to things like HIV/AIDS, mental health conditions, and trauma. At that time, that was also a pivotal point in history because we were no longer we're still concerned about building a nation on the backs of our immigrants, but we actually started to bring people in that had less literacy, less education. So that was really interesting. I think I'm going to go to the next slide. Okay, and then what happened? Okay, then we started to get interested in gender. Immigration Canada changed its name to Immigration Refugee Citizenship Canada. And so at that, I think it was in the early 2000s, I apologize if I don't have the exact year, adopted what's called a gender-based plus analysis. And that was really to try and provide a more of an evidence-based approach around the gendered impacts of health, and to look at gender and gender-based policy in all policy programming. And the plus in GBA plus acknowledges that we need to go beyond sex, beyond gender and differences to consider how race, racism, ethnicity, age, disability, sexuality shape people's experiences with the policies and the programs. And one of the critiques of this is that it still tries to treat these categories as static. So today you heard Dr. Kevin Pody talk about transition, and that's an interesting concept that I hadn't thought about because intersectionality is actually not about static categories. It's actually about fluidity and change and perhaps transitions. So in 2022, the World Health came back and they said, you know what? We need to address the structural determinants of migrant health, such as economic security, good quality infrastructure, equal access to services, quality of their environment, but also social justice and integration, income protection, and at the forefront, social and gender equity. So in this context, we've tried, like other nation states, to adopt what's called a gender-responsive approach, and to look at disaggregated data to include those categories of income, et cetera. And I know Kyla originally talked about how disaggregated data can put people into boxes, but we have to be mindful that sometimes we might need to do that for strategic essentialism. In other words, to look at, well, what are the root factors of inequity? I think I'm talking too long, but anyway. Okay, so then I'm interested, again, around health policy, systems, intersectionality, and according to World Health 2021-22, I looked at, okay, so what is upscaling mental health services? What's the policy? What's changed from the 70s, 80s, 90s up to the 2000s? Okay, still require a strong focus on local understanding, community experience, and solutions to scale up initiatives that are grounded in social justice and equity and human rights. And as our dialogue has shown, integrated care involves multi-sector collaboration with primary healthcare services and those outside the purview of health, so not-for-profit agencies, schools, settlement organizations. So that's what I'm talking about when I mean scaling up migrant mental health for better evaluation of how social and structural inequities are reproduced. And there needs to be a better evaluation of what are the programs that are being developed for migrant mental health. Somebody's moving this, and I don't know why, but okay, anyway. No sleep. Okay. So World Health Organization, that's the policy, committed to an action plan, looking at upstream factors, back to community-based approaches, the need for integrated care, and the key focus is on better evaluation. And most countries have only spent about 20% of their health budget on exactly what the WHO is recommending. I have more stuff, but I'll just keep going. Scaling up mental health frameworks can benefit from pragmatic evaluation methods on what works, why does it work, and what interventions work for who and how. So I was lucky enough to get a grant from Michael Smith Health Research BC to do what's called convening and collaborating of settlement service providers, primary care providers, people with lived experience, basically everybody that was interested in immigrant refugee mental health in our province of BC. I had 25 people across those sectors, and we engaged over 10 months in deliberative policy dialogues to find out what context, programs, resources worked to promote migrant mental health. And in the discussions, what you're looking at here is a capture of those discussions over 10 months, where we all came back together in a World Cafe at the Center for Migration Studies at UBC. And the key themes that came out of this beautiful diagram was continuity. We need better continuity of care. We need to address capacity, meaning human resources. We need better equitable access, meaning brokers, health workers, et cetera. And we need attention to not only person-centered, but inclusion of family and family networks in care. And when I started to, so that was fine, we had that discussion, but when I started to dig deeper in that analysis, preliminary findings suggest that the context of multi-sector relationships shapes the care work that people are doing. So caring could be a key mechanism for integration of mental health services and supports. And I was also interested to know that that came up in Kyla's talk, that it's really important that someone cares about you. So I thought that was really interesting. If you want to know more about this, this visual graphic, the yellow dots, if you click on them, they actually go to reports and some of the photographs that were done in this World Cafe. So without further ado, I've talked enough. Dorota will now provide a brief overview of where we think digital mental health sits in the context of integrated mental health care and its contributions and challenges.
Thank you, Nancy.
You don't have to clap.
All right. Okay, so as Nancy mentioned, I will just go over briefly over the concept of digital mental health, including definitions, approaches, as well as current gaps. Just switch the slide. Okay. So when defining digital mental health refers to the services targeting health problems via online and mobile technologies. However, the concept is very broad, and there are different terms used, such as e-health, m-health, virtual care. And encompasses various digital technological modalities as well as uses, including smartphone, mobile applications, websites, telehealth, text messaging. And the uses are also different. So they can be designed for online or offline use, synchronous, asynchronous use, as well as different purposes, such as self-management of conditions, adjunct to other therapies, for example, mood tracking apps, appointment reminder apps, can also be used as therapy. So for example, a CBT treatment with apps that use AI, like chatbots, to deliver personalized support. Also for general mental health promotion, such as with meditation apps, or for education, so for e-learning modules regarding mental health for healthcare practitioners, or to be used as an assistive tool, as well as for patient education. And there's so many uses. So it could also be for help with system navigation, as well as we well know, virtual care, and as a platform for communication, either in a synchronous way or asynchronous way, with healthcare professionals or peers. Many of the digital mental health approaches actually often use a combination of different modalities. So overall, digital health approaches are seen as a promising opportunity to address mental health challenges of populations, especially for those facing access barriers. So the World Health Organization guidelines actually recommend the use of self-help psychological interventions for depression non-specialist delivery of interventions, including technological approaches. So one notable example is the step-by-step app, and you can see a graphic there, which is an image from the app. So this is an app that was actually developed by the WHO for use in low and middle income countries. So yes, it's called Step by Step. And WHO said it was designed as a global public good, designed to be implemented by government or organizations providing coverage to large populations. And it provides psychoeducation and training in behavior activation. And with the content is actually delivered through the app, starting with questionnaires, assessing mood, functioning, and identifying various problems for the individual. But it also uses e-helpers, which are non-professionally trained university graduate, which provides support, direct support via phone in a synchronous fashion, or asynchronous if preferred as well, to provide technical as well as emotional support and motivation to use the app, as well as assess patients for any risks such as suicide and any potential harms. And it was also designed to be adapted and used in different settings and different cultural contexts. There was actually an RCT that evaluated this app, and it was deemed to be effective. And it was the participant group was Syrian refugees in Lebanon. All right. 2 minutes. Okay. All right. And so just to go over some major known findings and gaps regarding mental health, digital mental health, in particular in relation to migrant and refugee populations. So we did I'm just going to jump to the section where we did a brief overview of the literature that's currently available on the topic. So specifically, actually, refugee digital mental health. And based on the literature, preliminary literature review, currently there's very limited research on this topic, which is somewhat surprising given all the investments and interest in the area. And there's not actually much Canadian-based research on the topic as well. But there are a number of reviews that currently exist, including systematic and scoping reviews, with some interesting conclusions that they provided, namely that most digital health interventions for this target population do show success, although there are some contradictory findings, as well as high dropout rates. And that currently there are non-smartphone delivered interventions that currently meet the needs of the respective population comprehensively, and that the specific needs of populations are not yet fully understood. Findings also point to the digital divide that was mentioned before, and also many studies point to the need to include those target user groups when designing interventions. And in terms of major gaps, so currently, as mentioned before, there are a few studies that target the specific group of refugees and migrants, as well as ethnic minorities in general. There's also a lack of integration and evaluation of digital mental health in health systems and policies, as well as the use of these resources throughout the trajectory of migration with touch points as they access the Canadian healthcare, as individuals access the Canadian healthcare system, and as well as for healthcare practitioners, specific protocols of how to use these technologies, when to use them, with clear protocols. And okay, well, thank you.
Okay, we've been called to wrap it up, so I'm just going to close real quick. In our final slide, we don't really have one. We were trying to figure out what to say. How do you conclude? We just have more questions. There's a need to upscale integrated mental health. What is the role of digital health or mHealth within the context of integrated mental health care? Integration of care is very complex. We talked about intersectionality as a critical complex theory aimed to address some of this complexity. And also, again, to really look at the social determinants or the structural determinants, and how does digital tech health or mHealth fit with that. Kevin mentioned the need to talk about working with whole systems. And so I think that's an important takeaway, that we have to try and mitigate these silos. That's what evaluation of a mental health program might look like. And that the concept that I learned today was this concept that was also brought up of transitioning, the fluidity of people, places, and migration, and also status of health and illness. In context, in relationship to those structures. And we're considering, so what role does mHealth and technology have in relation to other things that work for mental health, such, Bukola already mentioned, community belonging, peer support, socialization. And just a final note that who's left out? Who's left out of these conversations? So we've talked a little bit about gender. We haven't talked a lot about age and ageism or abilities. And we learned that everyone might have a smartphone, but not everyone is literate. And again, who's left out of that resource or that access? So I think it's an important point to leave you with. As we consider policy for digital mental health, and also how we can consider closing some of the gaps and opening up more opportunities. Thank you.
Thank you, Nancy. Thank you, Dorota. I look forward to the question session afterwards. And now to introduce our final panelist is Dr. Akm Alamgir, who is a leading researcher and educator specializing in evaluation research, epidemiology, and medicine. As Director of Knowledge and Learning at Access Alliance in Toronto and an adjunct professor at York University and the University of Toronto, he bridges academia and community engagement. AKM's research focuses on health equity for refugees and immigrants, mental health resilience in youth, and expressive arts therapy for survivors of gender-based violence. He actively shapes national standards in youth mental health and contributes as an expert reviewer for government initiatives. With over 50 publications and involvement in transformative research, AKM is dedicated to advancing equitable healthcare practices and addressing newcomer health challenges. So please help me welcome Dr. AKM.
It's my privilege to be here. I feel honored. I see some big scientists, Bukola, and that I work with. Thank you, Bukola, and your team for inviting me to speak to this session. I have mixed level of privileges. I'm a first generation immigrant. I have the privilege to this land that my previous scientists, they mentioned as acknowledgement. I agree with all of those. along with the land, I also acknowledge the resources that I enjoy here as privileged that belongs to the indigenous people. And I feel shame for the abuse that happened to them, for the residential schools, for the sterilization programs, and all other types of physical, mental, inhuman abuses happened to them. And I'm grateful to them. Thank you very much. My journey, I will start with my organization that Ibokon told that may fit better. So I'll speak about the organization that I work with. I started my life as a medical doctor, as a surgeon. Because of my long height, tall stature, I had to quit it because always I had to depend on some tools. And nobody, no nation, no community can depend on support always. So that is my equity research that I will share with you. So I started working on cardiology, practicing cardiology, cardiac epidemiologist, then evaluation research, and yes, I work on social determinants of health with Access Alliance. Access Alliance is a non-profit community health organization in Toronto. We started with 4 founding communities in Toronto in 1989 through different stages of acclimatizing with the changes of the policies, changes of the need of the community. Responding to the need of the community, we are here now in 2024. Sorry, this slide was 2023, so we are here 2024. We serve newcomers, immigrants, refugees, and everyone in Toronto. Everyone means everyone. So what does everyone means? Because the everyone means we serve Canadians who are not immigrants. We serve people without status, non-status. We serve with healthcare. We have non-insured walk-in clinic. We serve people who are refugees, who are asylum seekers, who are international students at different stages of precarious immigration status. We serve them, everyone who knocks into our door. If they don't come to our door, we go to them through peer outreach program. We go to the community. We go to the schools to understand the need, to meet their need. If we can't serve, we guide them to serve. So we have the primary care, that is the core service that we provide. We have salaried doctors, nurses, nurse practitioners. To support them, we have allied health services. For mental health counselor therapists, we have registered dietitians, we have health promoters to support them, support clients, support the residents of Toronto and beyond. We have settlement services, we have group programs, family programs based on gender, based on sexual orientation. We have LGBTQ clinic, we have LGBTQ programs, we have seniors programs, we have youth program, we have program with families, we have program at hotels, hotel clinics. So we serve everyone. And from the morning, as Bukola said and Kevin told, yes, that language. Everyone told language is a big barrier. We have a robust language services. And you may not believe me, you may not trust me, but it is true that we can provide language services online to 102 languages 102 languages and major dialects within 28 seconds. Less than 30 seconds, not minute. So that's the robustness of our language services. And our research department is Organization Knowledge and Learning that I lead. We have this department that I lead, starting from student placement to data management and planning evaluation, all these pieces. So when we provided service to language services, when we generated evidence, what are the unmet needs? We found that if someone is newcomer, if someone is hesitant to express their pain, are not sure about trust, level of trust to share their pain, language, literature, language is not the only medium, may not be the perfect medium. We started introducing expressive art as identifying the pains, identifying the trauma, identifying, because we don't want to trigger them. When collecting data, we don't want to trigger them. But we can ask them, can you sing a favorite song? Then when we analyze that song, then we can see where they are from, what is the pain, because people express themselves there. That's how we started identifying expressive art. And we did not stop there. Then we started expressive art as a therapy for intervention. We started expressive art for identification of collection of data, generation of evidence. Then we are running a program that Bukola knows. Last 2 years we are working on. We completed with 3 communities. We'll continue with 3 more subset of population this year. Gender-based violence by healing trauma by expressive art therapy. In that research, we considered structuralism, how it impacts the pain, trauma, abuse. We are following a constructivist approach to include their pain, include their information, include their data, include their, it is not data, it is their life cycle, it is the story of their life. We are not labeling them as data. It is their life. So we are doing that. And yeah, we could complete with Arabic speaking group, and with Bukola's help, we could complete with Afghan refugee group, not refugee, Afghan women group. We completed Bengali speaking group. Then this year we are continuing, starting with Tigrinya group. Then we did a separate group with LGBTQ, members of the LGBTQ community, and a separate group, abused women living in shelter, because that's a very siloed group and we know less about them. And because they are very transient, so we are very mindful about it. So that's how what do we do at Access Alliance? Yes, from the morning he spoke about that, now it is redundant. Now it is redundant. So, yes, it is redundant, but still not dropped, because in most of the cases, Access Alliance found that we deal with integration, factors for integration, challenges for integration, barriers for integration, facilitators for integration. We are working with them. But marginalization. We are not thinking other siloed peoples, other people, why they are, like Yazidi group of people, why they are separated from the mainstream. I know some families, they are separated from the mainstream because they don't trust me. They don't trust us like those families. Roma Hungarians, that is another group of subset of population. They don't want to share their information deeply with others because report building, trust, and yeah. Recently we came across one group, Tibetan group. So when we heard about from them, it was simply painful. They are nowhere. They feel that in Canada they are nobody. When they go back to Tibet, they are nobody. That this is not. They are landless. They have no sense of belonging anywhere, neither here nor there. So we also work with them. So this is redundant, but still we continue work other groups to them. So this is our research philosophy, if you do not know that we do, and these are our methods. Usually we do mixed method. Previously we used retrospective and prospective as mixed method approach. We used qualitative and quantitative. Now we added art-based as additional layer. So our mixed method, if AKM says mixed method, that means quantitative, qualitative, and art-based, because we want to include everything. And an inclusive model. In our data analysis, I learned from Michaela, she is my mentor. So what we do, in addition to the client data, participant data, we also include reflection diaries into data as data supplement. We make weightage of the data with those. And abductive philosophy, Pierre's abductive philosophy, that is my favorite as the realist evaluation person, that is my favorite. It is neither deductive nor inductive. And to do it, usually we follow outcome harvesting approach for evaluation. So that intended outcome, unintended outcome, and the slope, that is the distance between the intended and unintended outcome, and quantification. And when we do art-based evaluation, we also do quantification. So yes, we do this. And for gender-based violence particularly, we are practicing interpretive phenomenological analysis, because story of one person is not same as story. It is not that aggregation. We love aggregated data, but aggregated data may not lead me to any solution, any benefit when we say traumatized people, trauma-informed care. So we started from last 2 years, we started phenomenological study, interpretive study. And this is the abductive logic model that I mentioned. Yes, we are not abandoning the deductive idea, we are not abandoning the inductive idea, we are including. So our model is inclusive and democratic. And that's how, when we set a research, that's how we put the research impact at what are the benefits at the individual level, because from those who collect data, how they are benefited, how we report back to them and create a product that is useful to them. That is individual and interpersonal level, that we always keep in mind, that what we are doing with the population from who we collect data. And at intermediate meso level, community capacity building, community awareness building, community advocacy building, and we do that. And at the system level. One example I can give you, few years before we worked on, poor jobs make us sick. That is, it was $11 minimum wage at that time. We generated evidence. We found that the salary wage should be raised in Ontario. So we set a level 14. We worked with academia, we worked with community organizations, advocacy groups. We went to Queen's Park, we wrote op-ed, and everything. At the end of the government was very resistant and yes, very annoyed with us because we generated the evidence at Access Alliance. And then ultimately it happened. They made it $14. So that is the impact, the system. How do we change the system? Like right now we are working on unaccompanied refugee youth. There are some gray areas that we are preparing some documents so that we can argue to the government, argue to the policy planners that, hey, this unaccompanied refugee health, immigrant, we want to, again, I go back, we want to demystify, unpack immigrants from immigrants, and all immigrants are not same. Refugees and economic immigrant are not same. Their journey is not same. As she was saying that before arrival to Canada, they have a painful story, different from that I purchased the ticket, I got the visa, and I came to Canada. It was smooth like from one heaven to another heaven. But their journey is not like that. They are deprived, they were oppressed, they are abused in their home country. They were forced to leave their country. And we have to go to another country, another perspective. They were deprived, they were deceived, they were abused physically, mentally, economically, financially. And then they come. So they have long history. So refugees are not like non-refugee immigrant. Again, among the refugee, youth are not like adult refugees. And among youth, unattached, unaccompanied youth are not like the accompanied youth who came as refugee with their parents. So we try to unpack those things. What are the nuances? What are the areas that we don't see? So we advocate peer researchers. When we work with refugee youth, we hire peer researchers from refugee population. They know their pain. Like just we completed the research on diabetes among black, African Caribbean black adolescent. So we hired one peer researcher who is from Nigeria, who is a doctor from Nigeria, not registered yet. So we hired him as the peer researcher. So he could have better outreach to their community because people trust him more than Akm. This is the level of rapport building, trust building, and he can explain in his English and his own language about the objectives that yes, this test, blood group, this diabetes test is better for us. So if I say it is good for us, they may not trust me. So that's why we follow this peer model. So yes, and that is about Access Alliance. So we have some methodological concerns and methodological concerns because we are a community organization, not an stamped research organization. That is our concern. And complexity and pluralism, that always we feel the client that we serve, they are very complex. Comorbidity. So we have started at our organization, just last sentence, we have started in our organization one thing, which is social prescription, integrating medical prescription, medicine with social prescription. So our doctor, we started with non-insured walk-in clinic. Those people are very much marginalized and they have more equity deserving people, that people without status. So we started social prescription along with medicine prescription. So if someone has comorbidity like diabetes, mental health and comorbidities, we add a social prescription component with it. That is our last edition. Thank you very much.
Thank you so much, Dr. AKM. At this time, I would like to invite the four panelists to please come and join me up front for a Q&A session. So Dr. Nancy, please, Dr. AKM, Dr. Bukola, and Dr. Michaela, please. First off, I would like to... Can you hear me? Yes, okay. I would like to thank all of our speakers for these thought-provoking and engaging topics. I know myself, I'm full of questions. However, I would like to share, and I would like to ask the audience first if there are any questions for any of our panelists, or even if it's a general question from the floor.
Yeah, we had a question from the Zoom chat for Michaela prior to the break. In your experience, do you think that we need an academic as well as a practice shift in healthcare in Canada for equity-seeking populations? A lot of research has been conducted, but translating that research and having some transparency and data ownership from communities is integral for any strong integration mechanism to work better in our country.
The short answer is yes. I think many of us here work collaboratively with community organizations. Certainly, I've worked for many, many years with Access Alliance and with AKM. And one of the principles of the work that we do is that the work is with communities, and therefore, when you're doing the academic work, you are also thinking about translating that work in collaboration with your community partners into something that is immediately usable by the community, whether that's usable for practice, whether it's usable for advocacy. And I don't know that, while I do think that's happening increasingly in some areas, it's not happening across the board. And yeah, I think that we could be doing a lot better with that.
Thank you. Any other questions from perhaps Zoom chat or the floor? Not at this time?
Where did the fellow go that was asking all the questions all the time? Where did he go?
It's right there.
I'll just add to that in terms of the need for community engagement. I think oftentimes we do research, and there's like a divide between community and research. And that is part of the colonizing process, right? Who has the knowledge, right? And things. And I would say the true crux or beginning of a decolonial approach is thinking about why. Why conducting the research, and who benefits from the research. So research for what is one of those things. And I think that involves meaningfully engaging the communities to sort of to determine what research agenda they want to set for themselves rather than we setting for them. And I think oftentimes, when people talk about, I think, now they talk a lot about patient engagement, not community engagement. Again, coming from an individualistic Western perspective of patient. And when they think about patient engagement, they just think, okay, how can we recruit, right? And how can, so it is how can they be of benefit to me? Not how can I be, and oftentimes people do not translate the knowledge to communities after or present the knowledge to communities after. And I think we have to start thinking about research, not just in terms of engagement during data collection, but also engagement from formulating the research question to also translating the knowledge back and co-mobilizing the knowledge to communities.
Yes, Ibukun.
Yes, sorry. I had a question related to the fact that all four speakers, in one way or the other, talked about either policy or advocacy or trying to shift the system. And I was wondering if any of you could speak to like practical approaches to doing that, right? Because it's one thing to know that this is what we need to do and the theories behind it and what we expect to achieve. But then getting from there to the how, the everyday how do we do that as researchers, as graduate students, as people working in the settlement sector, as community organizers? What does that mean in practice?
That's a good question. Is it okay if I respond just because it's on my brain right now? Intersectionality theory always worked from the bottom up. So it's about changing structure with political, what they call political intersectionality, meaning that people who are directly impacted by the systems, by the social structure, are creating the policies. So it's giving a seat at the table. It's a very short brief.
Yes, I'll just mention one thing. So, my first research with Black communities was a project on parenting and mental health promotion practices of African immigrants. And early on in that project, I had an advisory committee. And there is a woman there that I ended up nicknaming my favorite volunteer because she got tired at some point of volunteering for me, which made her, in a meeting, when they were looking for someone from Western Canada to come talk to the Prime Minister on how to address COVID-19 pandemic within Black population, she said, she thought to herself, she said, all those data you have collected should have worked somehow, right? So what I'm trying to say is community engagement, because sometimes the communities actually amplify your work. And when it was time to change policy related to how to address COVID-19, that was how my name got forward, was just because I had invited her. The other thing that I am finding, that I just realized is, the House of Commons Standing Committee on Health, they have the studies every now and then. So they did one last year that was on child health. I was I was an expert witness on that. And they just had one recently that was on women's health, which I looked, there was no one, apart from Muslim Advisory Council of Canada, was the only group that made any submission on immigration or on race related to women's health. So I looked, and I'm like, so I assembled a bunch of people, and we made a submission on Black people's health to that. Because I am sure what happens with those submissions, from what I know last year, is that ended up going into a report, and then the report actually ends up making it into policy. So I think we have to, first is engagement, and second is looking at what are those policy spaces or policy windows where we can actually be able to insert our voice, insert some of the data we are getting to be able to actually create change.
Thank you so much. Because sometimes we focus too much on going to look on PubMed or Scopus, and the opportunity is right in front of us. Okay.
Yeah, I was wondering if I could also add to that. So, it was something that we were thinking about in the context, actually, of work that we were doing around access to healthcare for the uninsured many years ago. And Lisa Foreman spoke about how do you change policy? And she spoke from her own work in South Africa about providing access to antiretroviral drugs for low-income countries. And she said, we shifted that policy, and that seemed impossible. And we need to think about how that happened. And she presented Proasa Wesi's triangle that moved the mountain. Mm-hmm. And it has three core pieces to it. One, which is that one has to provide research that there is evidence available when there's an opportunity to apply that evidence. The second is that you need to leverage law and politics, and so you need to go through the courts because you will often have to force change to happen. And the third is that you shift public opinion, and you do that through thought leaders. And so it simplifies a very complex process, but it recognizes that these things all have to be happening simultaneously. You need to have the research ready for when that policy window opens. You need to work the levers that are available to you through the law, through the courts, and also through public opinion. And you need to get voting, using your power as a voter to shift public opinion, to make the policies shift. And you cannot do it unless you're thinking across the whole system and you're working in partnership and leveraging relationships across those systems. And that's why community engagement is so important, because communities vote.
Also, I can add from different perspective. At Access Alliance, we have a network, Immigrant Researcher Support Network. And we conducted a research about labor market integration of internationally trained physicians, couple of years before. We identified the issues, problems, and possibilities, and created a demand-supply curve that international trained physicians are available, and we Canadians need doctors for our care. Long waiting time, long wait list, and in the northern part, remote areas, no doctors. So we created an ITPAC, a coalition with WES. We started, during the COVID, we started the process that negotiated discussion with the government, Fairness Commission, regulatory bodies, colleges, and now if you see that Canadian Physician Association, or if you see some softening of the eyes, that if you see some changes, that system change, they're thinking about the availability of the internationally trained doctors, that is those research work converted to started system changes. And now we are hearing more stories about matching terms by international trained. That was totally unheard few years before. So that's the success story of how one research at an agency can create an agenda for a nation. Thank you.
Hi everyone, my name is Royaye Haqiri Vije. My pronouns are she and her, and for visibility and accessibility reasons, I'm mid-height, mid-size, curly hair, olive skin, just in case. Thank you so much for your presentation, and thank you for the organizers for this amazing session and discussion. I actually had a question for you, or maybe a comment. First of all, thank you for doing this work. And as somebody who escaped my country of birth with human smugglers, lived in a transition country for several years, coming here as an adolescent, being bullied around racism, around everything else, everything that you shared took me back to things that I have shoved pretty hard down deep. So thank you for this work, because I feel like 20 plus years later, those experiences being heard, work is being done. Going back to the theme of the conference around beyond technology, I know some of you had more slides that you wanted to talk to. So I was wondering if there's anything else that you wanted to add around that, and in particular around language and translation, and how you work with communities when it comes to AIs and translation and community building. And just a side note, I'm assistant professor at York University, so it seems like the people that I've followed, I actually see them for the first time here, so thank you.
Sorry. The question was about language and translation. So I think, in some of my slides, I did talk about the complexity related to language. But then there's even much more complexity to that, so especially when we think about mental health. When I did a study on parenting and mental health promotion practices, I would go into parents' home and I would say, I'm coming here to interview you. Okay, have a seat. I'm coming here to talk about mental health. They look around and they're like, no one is crazy around here, go somewhere else. So really, that's some of the challenges. But when we think more concretely from a service delivery perspective, there are many countries where the word mental does not exist, right? So you have the word I'm not sleeping well, I have back pain, I feel like sleeping all day, and so on and so forth. And what I have advocated for is really the need in terms of an anti-racist, inclusive mental health service delivery, mentioning the symptoms, rather than actually focusing much more broadly. Because in many countries, that's what it. So I think, just as you said, that AI also has to be cognizant of that fact in terms of the differences across spaces related to mental health, and also across also issues related to gender and issues related to race. So, for example, what is acceptable for a guy to be able to say their feeling may be very much different from what is acceptable for a female to be able to say that they are facing. So I think that's one of some of the key consideration in terms of thinking about language and the cultural context of language.
I'm not sure, but just for the record, there is no policy in Canada on equitable language interpreter services. That doesn't exist, and it should. I know there's a national network where guidelines have been developed. But we drew up those guidelines from very old data, and there needs to be policy around every single person has to have accessible care, whether it's having someone else with you, whether it's having an app, whatever, that's safe and acceptable. And to date, we do not have that policy in Canada, to my knowledge.
Sorry, from the audience, or I'm sorry, Michaela, did I cut you off? Go
I was
ahead.
just going to say very quickly, one thing that we did find when we were looking at access to virtual mental health care, two things that we found around interpretation. One was that the inclusion of interpreters in virtual care was actually problematic for certain individuals because there's now a third person in the room, and somehow having them in the room virtually was more threatening for individuals. And the other thing that we found was people saying that they would prefer to actually do the therapy in English, even though they didn't speak English as well, because there weren't terms in the language that they spoke as a mother tongue. And it was easier for them to express what they were experiencing in English than it was for them to express it in the language that they would normally speak at home, partly because of stigma and partly just because of lack of vocabulary.
Yeah, I think I can contribute here because, as I mentioned, Access Alliance is a robust language services. What is the meaning of robust? Not only the quantity numbers that I mentioned, the number of languages. We started, it's a long history, we started as translation. So translation and interpretation, these are two different things. Before the COVID, we practiced only on-site interpretation. That is, I am here, doctor is here, patient is here, interpreter is here. Then, during the COVID, actually, that brought the opportunity to use digital technology. So we started with telephone interpretation. We found that during telephone interpretation, we are missing the body cues, the non-verbal expressions. That someone says, do you understand? Say, yes. And someone says, yes. So this expression makes a difference. We also found that, as Michaela said, literacy, language, and health literacy. Like, how do I express tingling and numbness in my body in a foreign language? That started from if anyone speaks Farsi or Dari, then I can tell you there is a word in English in gender and sexual two-spirit. That is purely Canadian word. Now, when it translated into Farsi, then it back translated in that, because I speak Farsi as well. So what happened? it came out as two ghosts. Because two spirit, they translated in Farsi, because in Farsi there is no word, jargon like that. So they translated it. So this is cultural competency. So then we decided, and Minister of Health, now if you see that we told that, and it was at Access Alliance, and I was part of it, that no, we should write an interpretation of the Canadian words, like this, so two spirit. This is one of the examples. So like that, then we started AI, how AI can support our translating. Synchronized translation, asynchronous translation, consecutive translation, and simultaneous translation. So we are doing, experimenting all those pieces by our expert team. So we are using now synchronized, consecutive translation, but with use of AI that is like simultaneous, but we are not, the client is not paying for simultaneous. If you don't, yeah, I know you understand the word simultaneous, like someone in translating French, right away, what I'm saying. And consecutive means if I stop, then it starts translation. So, so right now we are doing simultaneous without paying for simultaneous. That is the use of AI, exploiting the capacity of AI that we can do. That's the new thing that I can tell you. Thank you.
Okay.
Oh, thank you so much. So much pressure. So thank you all so much. My name is Linda Bukai. I am a newcomer in Canada. I got here not a long time ago, so it's really amazing to hear what are you all doing, like all this important work. Most of my background is in mental health for refugee and immigrant populations in the US. I did a lot of work with unaccompanied minors. And I think you all touched upon very, very important things, such as how do we bridge service delivery at the community level with research? How do we bridge the evidence we produce in research with policymakers? And we use these policy windows to make sustain important changes at a policy level. But there's one thing that I was thinking about that I didn't hear much about, and I would like to know either your experiences or your thoughts on this. And is how do we bridge, how do we disseminate the results we have from our research? How do we amplify the voices of the communities we're working with for the wider population? Because we were talking about voting and influencing voters' opinions, and with a subject so, controversial or polarizing as immigration, how can we, as researchers, as community providers, also amplify the voices of the communities we're working with to influence public opinion and, visibilize their histories and their humanity and their struggles to the wider population? So I don't know if you have any thoughts about that.
Does anyone want to take a stab?
I'll just say, like, I agree in terms of, making things digestible. I think one of the things, the challenges that we faced, I think now in many of our universities, maybe not as much here, but much even stronger. In the US, we are having war on equity, diversity, and inclusion, war on anti-racism. And I think oftentimes it's because we discuss issues related to anti-racism, we don't share it much more broadly, or sometimes people feel very threatened. When you start discussing anything, people feel like, oh, it's not my problem, it's someone else's problem, and I'm going to be at risk if this, so then we get the backlash. Of course, one of the things that I always say is, let's think about the case of COVID-19. COVID-19 was a problem of someone else until we knew that it is our problem in Canada, that what happens in the world has an influence on us. So when we are thinking, for example, of the major global transformations, we are thinking, for example, of the issue of climate change, of the emerging technology, of issues related to immigration, and of course, of securities and insecurities. And we can always think, oh, these are all problems happening in other countries. they do not affect us. But, when we think, for example, in some of this, they have an influence on us. I think what you're trying to get to is how do we make Canadians much more sensitive to some of these issues? And I think it's also on how do we translate the knowledge that we are gaining in some of our broader research across the globe so that then it is in the public domain of Canadians. And I'm thinking, of course, there is, to what extent do we use media, including social media, to be able to amplify some of this knowledge that we are gaining broadly about, immigration and many of the conditions we face.
I just wanted to say it's an important question, and it's something that I struggle with all the time now that I have the luxury of doing research. But yeah, it's an important question, and looking at different ways, I just did something called photo voice and photo elicitation. I'd never done it, and I did it, and I'm like, wait a minute. Well, theoretically, staying true to that would mean that the people that engaged in that methodology, that it's actually them carrying the knowledge and actually disseminating it, not me. So again, checking back on my power and privilege and saying, okay, it's not me, this is your project. But then I'm stuck in a colonial system that has me doing certain ways and continually, so it's a continual challenge, I think, to try and think of innovative ways to tell stories that are compelling. And I'm not saying we don't need research. We definitely need the numbers. We definitely need to think about cost. That seems to appeal to politicians. But we also need to tell compelling stories and make sure that people are listening.
I think one of the challenges is that we don't always think of. I think that one of the challenges is that we don't always think about what we're going to do with the work until we're finished the work. And there is an approach to doing research with integrated knowledge translation where you begin the work with your community partners. You begin the work with an idea about who it is you want to share the knowledge with. And from the very beginning, before you even start doing the work, you're having conversations around, why are we doing this? Who are we sharing it with? What is the best way to share it? What are the messages that we're hoping to share? And if you haven't thought about that in advance, it's going to be a lot harder to have that happen effectively. I do worry that the work only goes out to the same. We're in a bit of an echo chamber, and the work always goes out to the same communities because I work with communities, and then we share the knowledge with the same community. And so I think there's also the importance of working across multiple sectors and collaborations and partnerships. So at the same time that we're talking about doing integrated knowledge translation, we should also be thinking about how broad is our partnership network? How many different kinds of organizations and partnerships can we engage in this? Who are some of the role models who might be able to shift people's thinking around this? The use of media and the arts, very powerful. But it's never simple. It's always process long term, and it's something that you're thinking about from the very beginning, and it's something that you're thinking about with everybody involved. And everybody involved means everybody who's involved in the process, including the people who make up the communities that we're working with.
Yeah, I am in a more privileged situation in this aspect because I work directly with the community. I live with the community. I serve the community. I collect data from the community. I go back to involve the members of the community for collecting data, their data. So it is research by the community for the benefit of the community out of the agenda that the community needs to make a change. So what we do, our knowledge mobilization is a continuous, ongoing process. What does that mean? Because peer researchers are always with me. They are the connections between the community and me always. And when we do at some stage, we report back to the community we have an advisory council for all of the researchers. Like Bukola is one of the important and supporting members of one of the advisory teams. So we different sectors, like for gender-based balance, our advisory team members, some of them are service providers, some of them are academic, some of them are survivors. So what makes? So we always share our updates with them. When we complete, we report back for validation. We call it evidence validation. That, hey, we collected this. Do you think it is surprise to you? Are you surprised? Or is there anything that you can add? Then we start town halls and then conventional articles and presentations in group things and all those. Those all steps we do according to the nature of the work. So our research start from the community, with the community, and go back to the community. Thank you.
I would just like to say a final thank you to all of our panelists. Thank you so much for everything, all the food for thought that you've brought to us today. And I would just like to say, I think it's also these forums where we can all come together, and we come from different sectors, we come from different academic disciplines, to share our knowledge, share about our experience, share about our research, and bring these together. In academia, we're often in my discipline, we're often in silos, and we don't get to translate our knowledge. And I think, these are just so important that we have these venues to do that. So thank you again. Thank you for everybody for making this possible, and for all the dialogue. May we continue.
Thank you so much. I really, really like to keep my word, and I said I'll have you out in the sun by 3.
It's sunny?
Be hopeful. I have sun. I think one more thing just on that final tone, the question at the end of the panel was, we should also remember that we are the community. And so in our own cells, networks, spokes, hubs, we are the disseminating voice, we are the voice of advocacy, and we are the voice of action. All right, and I wanted to come and sort of summarize everything we talked about today, but thankfully I don't need to do it because Delaney has already done it for us. So I'll hand over to Delaney for a couple of minutes to walk us through everything that she has captured in this really engaging day. Delaney?
Hi, I'm back here. I won't take up too much of your time, but yes, so this is what I have so far from the graphic today. A great sign is that it's very content heavy, which means that there is tons of excellent information. So I'm just now filling in all the drawings, and I'll do the colors, so you'll see that all tomorrow. Hopefully pretty self-explanatory, but I have the headings of each of the amazing speakers today, and all sort of the key notes as they're going through. One of my favorite things about this type of work is that actually there's so much interconnection. So even if there's a term that's not right underneath someone's talk, it definitely came up in someone else's. So words like obviously equity came up a lot, integration, migration, community, belonging, social connections. I tried to capture some of the stories as well, such as the family that was in Newfoundland, which is in the bottom corner there. I'll get those classic houses in there. And yeah, so please take a look. If there's anything specifically that you want on, I'll be here after, so you can come and chat with me. And then this will be all done for tomorrow, and we'll do it again.
Yes. Awesome.
Thank you.
Round of applause for Delaney, please. So thank you so very much for people who came from far and near to be part of these conversations with us. Isabel and I, in planning and thinking through this with the rest of the team, we're like, okay, how is it going to be different? We just did this like a month ago. And actually, it's different, it's complementary, it's energizing, and it's validating a lot of the reasons of why we started this inquiry in the first place. So with that, I will send you off for today, thanking you so much for your time. Thanks to Quest AV for all the work that you did. Tomorrow, we're going to gather here again for the co-design workshop. If you haven't registered, it's already too late. It's only in person. We're having people from the OHTs, settlement service organizations, people with lived experience of migration of all pathways, to co-design a best-in-class experience that is technology-supported but human-centered for newcomers to Canada. So we're looking forward to that. We'll be able to review Delaney's finished work, and she would also be working on a blank canvas to capture all of those conversations. If you're missing it tomorrow, we're sorry that you won't be there. However, we're having a website set up where all the recordings, all the outputs will be archived. If we have your email from the Eventbrite registration, then you'll get a link to the website once it's up and running. We want to continue these conversations, so feel free to reach out for ideas, something you're working on related to what was discussed, you want to connect with one of the speakers, you have follow-up questions. This is the work that we've committed to do, and we're always keen to learn, but also to unlearn and be challenged by others' views. Thank you to all our supporters and sponsors. Thank you so much, because your presence here, your engagement, your energy, and your insights have made this possible. I wish you well. For those who will be traveling back, safe journey, and keep in touch. Thank you.